Welcome. My name's Nadine and I'm going to be talking on the feasibility of linking clinical registry data to Medicare and pharmaceutical data in Australia. So in Australia, it's now possible to link researcher-held clinical registries with government-held administrative data sets. And this is in the absence of having a National Health Index identifier. These linkages are normally performed by health departments using personal identifiers such as name, date of birth, sex or address. And they usually use a combination of probabilistic and deterministic matching. So these types of linkages are relatively new for clinical registries, and so formal evaluations of the accuracy of the linkages and the impact for research are needed. Our cohort was derived from the Australian Stroke Clinical Registry, which is a prospective national clinical quality registry designed to monitor, promote and improve the quality of stroke care in Australia. Data are collected from all patients with a clinical diagnosis of stroke or transient ischemic attack admitted to participating hospitals and using an opt-out method of consent. Now, as you can see from the map, most of the sites are located on the east coast of Australia. However, that's where the majority of our population reside. Also within Australia, we have universal health care. So that means that all Australian residents and people with permanent residency visas, except for veterans, are covered for basic healthcare services. So we'd expect that most of our cohort would be able to be matched to Medicare. So then the aims of our study were to report the accuracy of linking data between these data sets and then to compare the characteristics of registrants whose data were and were not able to be merged and to identify potential sources of systematic bias. These are the data sets that were linked, and the OSCA contains a minimum core data set with demographic, clinical, processes of care and outcome data, including survival obtained through annual linkages with the National Death Index. In the claims data sets, really all we have in there are the types of claims that were made, when they were made, and who provided the service. I'll just run you through the process that we needed to go through in order to link these data sets. So firstly, the OSCA data manager had to extract the personal identifying information from the OSCA database and submit them to the Australian Institute of Health and Welfare. The staff at the data linkage unit there then took these variables and linked them to the Medicare enrolment file using a combination of probabilistic and deterministic linkages. This was followed by an in-depth clerical review. In the meantime, the OSCA data manager submitted the content variables from the OSCA into SURE, which is a secure virtual research environment hosted by the Sachs Institute. Once the linkages were complete, the AIHW submitted the content variable from the claims data sets into SURE, and then us, the researchers, were able to go in via a virtual computer and merge the data sets together and perform our analyses. For this project, we've used descriptive statistics to describe the proportion of OSCA registrants present in the Medicare dataset, pharmaceutical dataset, and then those who appeared in either of these two data sets. We use multivariable logistic regression then to investigate factors associated with registrant data not being merged. As there are no demographic details contained in the Commonwealth claims data sets, we're unable to validate the quality of the matches using common variables such as age or sex, which often appear in multiple data sets. Instead, we had to use the date of death obtained from the National Death Index in the OSCAR to investigate the proportion of Medicare and medication dispensing claims recorded after the date of death. So we ended up with about 18,000 people in our cohort, and for these there were about 2.5 million pharmaceutical claims and a little over 1 million Medicare claims. We had a 93% match rate with the Medicare, 95% with the pharmaceutical data, and 97% of people were matched with at least one of these claims data sets. When we looked at the characteristics of people who weren't matched, we noticed that people who were aged over 84 or 85 plus were not or were less likely to be merged in the Medicare data set. And we also noticed lower matching rates for people who were born in Asia. When we looked at our multivariable results, once again we saw that people who were aged over 85 were not matched or were less likely to be matched to the Medicare data. And we suspect this is because veterans in Australia are not covered under Medicare. They're covered by a separate scheme, and most of our veterans are aged over 85 years. We found that people born in Europe were more likely to match, whereas people born in Asia were less likely to match. This may be because a lot of the people in Australia who are on working visas or student visas and so aren't covered under Medicare come from Asia. But there's also evidence from other studies that due to differences in naming conventions, people born in Asia are more likely to have recording errors that can impact on the accuracy of linkages. In the pharmaceutical data, older people were more likely to be matched. And even though everyone who has a stroke should be on secondary prevention medication, we know from clinical evidence that this is less likely in people aged under 65 years. And once again, we saw similarities with people born in Asia. When we looked at the number of claims that occurred after death, we had a very small proportion of claims that appeared in the Medicare data set, and a little bit more in the medications dispensing data set, but that may have been people using the scripts after the date of death. And then there's always a few things that pop up that you just don't anticipate or wouldn't be able to explain, such as this. So the strengths of our study were that it was a large cohort with representation from most Australian states, and it also included metropolitan and regional areas. We had identifying data, so that meant that we were able to do these linkages, whereas not all clinical registries hold identifying data. The limitations were that we had a lack of common variables across data sets for linkage validation, and we weren't able to perform our own manual review of the linkages. So this meant we couldn't discern the difference between linkage errors, for example, due to misspelling of names, and the difference between people not appearing in the data sets, for example, ineligibility for Medicare. So in conclusion, we demonstrated the feasibility of linking a researcher-held clinical registry with government-held claims data in the absence of a national health identifying number. We also identified some potential sources of linkage bias, which are important for interpreting the results from research projects. And most importantly, this provided much needed pilot data for a much larger study that we're in the process of doing, where we'll be linking together approximately 7 routinely collected data sets. And finally, I'd just like to thank everyone else who contributed to this piece of work and the Australian Stroke Foundation for funding this study. Thank you.